Okay, what if we told you there's a type of, well, steroid that's been safely and effectively used in medicine for over 30 years?
Yeah, not for doping or anything like that.
Exactly, but to help patients, you know, recover from severe burns, fight muscle wasting in conditions like HIV, and even improve liver function in alcoholic hepatitis.
It kind of challenges the common perception, doesn't it? The compound we're diving into today is an anabolic androgenic steroid, or AASs, called oxandrolone.
Right, and while that word steroid often brings up negative images, our deep dive today is going to unpack its, well, frankly surprising and very well documented medical uses. So our mission today is basically to give you a shortcut to being truly well-informed on this really fascinating compound. We're digging into a comprehensive medical review from 2004.
A pretty detailed look at its effectiveness, its safety.
Yeah, especially in treating wasting and these catabolic disorders. We'll get into the science, understand its unique properties, look at the proven clinical benefits, and importantly, assess its safety.
Okay, let's get into it. To really grasp what makes oxandrolone stand out, we probably need a quick foundation on anabolic androgenic steroids, STLs, in general.
Good idea.
So at their core, these are basically derivatives or modifications of testosterone, the main male sex hormone, a powerful steroid itself.
Right, and they have this kind of dual nature, don't they? They're the anabolic effects and the androgenic effects.
Exactly. Anabolic is the building up part. Think protein synthesis, holding on to nitrogen, growing skeletal muscle, tissue construction, essentially.
That's the desirable part, medically speaking.
Usually, yes. Then you have the androgenic effects. These are linked to male characteristics, primary and secondary sexual traits.
And in women, these can show up as side effects people definitely don't want, like male pattern hair loss, deeper voice, facial hair.
Precisely. And historically, separating those two effects, getting the muscle building without the masculinization, that's been the big challenge.
So how do they actually work? At a molecular level?
Well, mostly they work by binding to something called the androgen receptor, the AR. It's a protein in our cells.
Like a docking station.
Kind of, yeah. Once the AAS molecule binds to the AR, this whole complex moves into the cell's nucleus.
Okay.
And there, it binds to DNA and basically tells the cell machinery, hey, make more protein. These new proteins then do the work the hormone is signaling for.
So the AR is like a specific lock, and the AAS are the keys.
That's a great analogy. The issue is this lock is in muscle tissue, which is good, but it's also in reproductive tissues and others, which leads to those androgenic side effects. It's hard to make a key that only fits the muscle lock.
Makes sense.
But that's not the whole story. They also work indirectly. For instance, they can interfere with the glucocorticoid receptor.
Glucocorticoids. Those are stress hormones like cortisol, right? They break down tissue.
Exactly. So by antagonizing that receptor, AS help inhibit protein breakdown, or catabolism. We see this with testosterone reducing muscle breakdown in severe burn patients, for example.
Okay, so they build muscle and prevent its breakdown.
Right. Plus, they can boost the liver's production of IGF-1, insulin-like growth factor 1.
Another muscle builder.
Yep. And some evidence suggests that they might suppress myostatin, which is a protein that naturally limits muscle growth, so they take the brakes off too.
Wow, okay, so multiple pathways leading to more muscle mass.
Understanding these mechanisms helps you see why they're so potent, but also why you get this package deal of effects, both good and sometimes not so good.
Right. It sets the stage for why finding something different, something like oxandrolone, was so important. We've got this picture of caressed, powerful builders, but often carrying that androgenic baggage. The dream was always a key just for the muscle lock. How did oxandrolone, made back in '62, manage this?
Well, its chemical structure is really quite different. It is a C17 alpha-alkylated AAS, which is common for oral steroids. That modification helps it survive the liver first pass.
Okay.
But how it's structured beyond that is unique. It has an oxygen atom swapped in where others have a methylene group at the 2 position, and it's missing something called a 4-ene function in its I ring.
Sounds technical, but you're saying these small structural changes are key.
Absolutely key. They fundamentally change how the molecule behaves in the body, especially regarding metabolism and side effects.
Okay, so structure is unique. What about pharmacokinetics? How does the body handle it once you take it?
It gets absorbed pretty well orally. You see peak levels in the blood after about an hour.
And how long does it stick around?
The elimination half-life is around 9 hours, so it has a decent duration of action. It's also highly protein-bound, about 95%.
Got it. Absorbed well, lasts a while. But what about metabolism? You mentioned structure affects that.
And this is the big deal with oxandrolone. Unlike many other oral ACE that get heavily processed or metabolized by the liver.
Which can cause liver strain, right?
Exactly. Oxandrolone is remarkably resistant to that liver biotransformation, that unique structure we talked about. It inhibits the typical metabolic pathways.
So the liver doesn't break it down as much.
Much less. In fact, about 28% of it is excreted unchanged in the urine. That resistance is huge for its safety profile, especially liver safety.
Wow, okay. That's a major difference. So structure leads to less liver breakdown. What about what it does in the body? The pharmacodynamics.
This is where it shines. It has strong anabolic activity, muscle building, but relatively weak androgenic effects.
So it managed to separate those effects better.
Significantly better. Its anabolic to androgenic ratio is often cited as around 10.1, which is much higher than testosterone or methyl testosterone. In humans, its anabolic punch is about 6.3 times that of methyl testosterone.
And toxicity.
Animal studies show very low toxicity.
So for you listening, the takeaway here is this unique structure isn't just a chemical novelty. It leads to less liver metabolism and a much better ratio of muscle-building effects versus masculinizing effects.
It really is a different kind of oral steroid, and that's critical when we get to the safety discussion.
Okay, so we've established it's structurally unique, handled differently by the body, and has this favorable anabolic androgenic ratio. What does that translate to in the real world? What are the proven clinical uses?
Well, the U.S. FDA has actually approved it for some pretty specific things: restoring weight loss after major trauma, surgery, or chronic infections.
Serious situations where people lose a lot of body mass.
Exactly. Also for malnutrition related to alcoholic cirrhosis and even certain types of muscular dystrophy, like Duchenne's or Becker's.
So these aren't trivial conditions.
Not at all. And the review of studies shows strong evidence for its effectiveness across the board. You consistently see improvements in body composition, more lean mass, less fat, plus better muscle strength, better function, faster recovery from injury, and improved nutritional status in most well-designed trials.
Let's get specific. Burns, for example. That's a state of extreme catabolism, right? Muscle just melts away.
Terribly so. And oxandrolone has shown remarkable results there. One study found it enhanced muscle protein synthesis by over 100% compared to controls.
Doubled it. Wow.
Yeah. It also significantly cuts down weight loss, nitrogen loss, which is a marker of protein breakdown, and can speed up healing. Think 30% faster healing of skin graft donor sites in one study.
That means shorter hospital stays, too.
Absolutely. One trial reported hospital stays reduced by about 35%, fewer complications, potentially better survival rates too.
That's incredibly impactful for those patients. What about other acute situations like general trauma?
Similar benefits like improved prealbumin levels, which indicate nutritional status. Though, interestingly, a couple of studies did note slightly longer hospital or ICU stays, maybe increased rates of pneumonia or sepsis compared to controls in trauma patients.
Okay. So maybe not universally positive in every single acute scenario, but clearly powerful effects.
It highlights the need to look at specific patient groups. Now, shift to chronic catabolic conditions, like alcoholic hepatitis.
Where the liver is damaged, and patients often suffer malnutrition and muscle wasting.
Right. Studies showed oxandrolone led to improvements in body composition, liver function markers, and even survival rates. One study found a 17% higher survival at 6 months, and a 20% reduction in the severity of liver injury markers.
That's significant. What about something like COPD? Chronic lung disease often comes with muscle loss, too.
Yes, it does. There aren't as many big controlled trials here, but the uncontrolled studies suggest similar benefits: better body weight, more body cell mass, improved functional status.
Yeah.
Promising, but needs more research.
Okay, and then there's HIV or AIDS-associated wasting. That was a huge problem, especially earlier in the epidemic.
A devastating problem. And multiple studies show oxandrolone produces positive results here, improving body composition, muscle function, nutritional status.
Does combining it with anything else help? Like exercise?
Great question, yes. Combining oxandrolone with progressive resistance training showed significantly better results than either alone.
Synergistic effect.
Seems like it. Greater gains in body weight, like 2.5 kilos more in one study. Better nitrogen retention, more lean body mass, even better bone mineral content, less fat mass, and boosted muscle strength and function.
So exercise plus oxandrolone is a powerful combo for rebuilding.
Definitely. But even on its own, say 15 milligrams a day over several months, it showed continued weight gain, improved appetite, and better physical activity levels.
What about neuromuscular disorders? You mentioned muscular dystrophy earlier.
Right. In Duchenne's muscular dystrophy, studies reported benefits like increased body weight, about 1.6 kilogram, a bit more height gain, and improved muscle strength scores.
And spinal cord injury. That often leads to pressure sores and respiratory issues.
Here, the results were quite striking in some cases. One study found complete healing of previously non-healing pressure ulcers in nearly 90% of patients treated with oxandrolone.
90%. That's incredible for something notoriously hard to heal.
It really is. And improvements in respiratory function, too, like a 9% increase in combined lung function measures.
Okay, this is a broad range of applications. Any other sort of miscellaneous uses noted?
A few interesting ones. In obese men, it was shown to decrease visceral fat, the dangerous fat around the organs, by about 35 square centimeters, while increasing thigh muscle area.
So shifting body composition favorably even in obesity.
Seems so. It also showed benefits in lowering triglycerides and cholesterol in certain specific types of hyperlipoproteinemia. And in a rare condition called hereditary angioedema, it helped control the disease and reduce the frequency and severity of swelling attacks.
Wow. So these examples really drive home the point. It's not just theoretical. Oxandrolone has demonstrated tangible benefits across a wide spectrum of difficult conditions where muscle loss, wasting, or poor healing are major problems.
Absolutely. It highlights its direct clinical utility in helping patients facing serious, debilitating health challenges.
Okay, now for the crucial part. Safety. Because whenever you say steroid, alarms tend to go off, especially regarding side effects. We know other AAs, particularly the oral C17 alpha-alkylated ones, have a bad reputation for liver toxicity, cardiovascular issues.
Right. Things like cholestatic jaundice, where bile flow stops pileosis hepatis, which is blood-filled cysts in the liver, hyperplasia, adenomas, even liver cancer have been associated with other A's, often at high doses used for long periods, like over a year.
So how does oxandrolone stack up against that grim picture? You mentioned its unique metabolism earlier.
And that is the key distinction here. That resistance to liver metabolism conferred by its unique structure really sets it apart.
So did the review find those severe liver problems with oxandrolone?
Generally, no. The review specifically notes that oxandrolone did not exhibit the more serious adverse hepatic effects attributed to other C17 alpha-alkylated AS in the studies they looked at. No specific cases of jaundice, pileosis hepatis, or liver tumors were singularly blamed on oxandrolone itself.
That's huge. So what did they see regarding the liver?
The most common things were transient, meaning temporary, and asymptomatic, meaning the patient didn't feel anything elevations in liver enzymes, transaminases.
AST, ALT levels.
Exactly. And also reductions in HDL cholesterol, the good cholesterol. Importantly, these changes usually went back to normal after stopping the drug.
How often did those enzyme elevations cause someone to stop treatment?
Very rarely. Out of 43 studies reviewed, only 3 reported needing to stop oxandrolone because of elevated transaminases. Just 3.
That's remarkably low.
It is, and there's an important nuance here, too. Elevated transaminases don't always mean liver damage.
Oh. What else can cause it?
Intense resistance exercise can cause muscle damage, which also releases these enzymes into the bloodstream. So it's possible that some reports of liver toxicity with other AASs, especially when used alongside heavy training, might be partly due to muscle breakdown, not just direct liver harm.
Interesting point. Needs careful interpretation.
Mm-hmm.
Okay, so liver safety looks comparatively much better. What about other side effects, the androgenic ones? You mentioned the good ratio, but did they still occur?
They did occur, but seemingly quite infrequently, considering women were included in 30 of the 43 studies.
Okay, so plenty of female participants.
Right, and across about 1,000 patients in 27 studies that reported on this, androgenic effects, things like facial hair, acne, voice deepening, increased libido, were noted in only 14 patients total.
14 out of 1,000. That seems incredibly low for an AAS.
It really does attest to that favorable ratio. Now, it wasn't 0. 2 female patients did stop treatment because of these viralizing effects, but overall, the incidence appears remarkably low based on this review.
What about cholesterol changes? You mentioned lower HDL.
Yes, that was the main effect. HDL cholesterol often dropped significantly, sometimes 36–47% below baseline levels.
That's quite a drop. HDL is protective, right?
Generally considered protective, yes. Some studies also saw increases in total cholesterol, or LDL, the bad cholesterol. The big question mark is the long-term cardiovascular impact of these changes.
Why is it a question mark?
Because most of these studies were relatively short-term, we don't have long-term data from these specific clinical trials to know the real-world consequences years down the line.
Fair enough. Any other side effects pop up? Psychological?
There were some reports, 13 patients in total across the studies experiencing transient psychological effects. Things like mood swings, agitation, irritability, anxiety.
Okay, relatively small numbers again.
Yes. And edema, or swelling, was reported in some elderly patients, especially those who already had conditions like heart failure or COPD, which can predispose them to fluid retention anyway.
Makes sense. And the big one people worry about with male hormones, prostate cancer.
It's a general concern for all AASs because they are related to testosterone. However, in the studies reviewed covering oxandrolone, no cases of prostate cancer were reported.
But again, long-term follow-up is needed.
Absolutely. As with any hormonal therapy, long-term monitoring is crucial.
So the picture that emerges is, yes, there are potential side effects like the HDL changes and the low risk of androgenic or psychological effects. But compared to other oral AASs, especially regarding the liver, oxandrolone seems to have a markedly better safety profile in these clinical settings.
Exactly. It underscores that you can't paint all steroids with the same brush. Oxandrolone stands out, making it a valuable, albeit carefully considered, tool in specific medical situations where the benefits clearly outweigh these manageable risks.
Okay, so we understand its past and present uses and its relative safety. Let's look ahead. What about future potential? A huge issue with aging is sarcopenia.
Right, that involuntary loss of muscle mass and function as we get older. It's a massive problem, leads to weakness, falls, disability, loss of independence, higher mortality. A growing concern globally with aging populations.
And is oxandrolone being considered for this?
It hasn't been specifically studied in large trials for sarcopenia yet, but it's considered a really attractive candidate.
Why? What makes it a good fit?
Because its known effects directly counteract many of the problems seen in sarcopenia. We know oxandrolone can decrease visceral fat, increase muscle protein synthesis, improve appetite and protein intake, enhance nitrogen retention, boost muscle function and activity levels.
Basically all the things you'd want to do to fight age-related muscle loss.
Precisely. Plus, it could potentially help substitute for the natural decline in androgen and estrogen levels that happens with age, which also contributes to muscle loss.
So it seems like a logical fit. What needs to happen to explore this further?
We definitely need more research. Specifically, long-term studies think over a year focused on older adults to really assess the efficacy and safety in that population for sarcopenia.
Dosage might need tweaking for older adults too.
Good point. Better dose titration to find the sweet spot, maximum benefit, minimum side effects. Maybe exploring intermittent therapy like cycles instead of continuous use.
What about combining it with other things like exercise or nutrition, which are also key for sarcopenia?
Absolutely critical. Studies combining oxandrolone with progressive resistance training or targeted nutritional support in older adults would be very valuable.
And what about women? Sarcopenia affects older women significantly.
A crucial area for research. Because testosterone has stronger androgenic effects, its use in women is limited. Oxandrolone, with its better ratio, might be a much more viable option for elderly women who make up a large portion of those suffering from sarcopenia. We need studies specifically in this group.
So this understanding opens up possibilities for tackling a major public health issue associated with aging. Imagine if a well-understood compound like oxandrolone could safely help millions maintain muscle mass and function longer.
It's a really tantalizing prospect for improving quality of life in later years. A lot of potential there.
Okay, so let's wrap this up. We've taken a pretty deep dive into oxandrolone today. We've gone past the usual steroid stereotypes to see its unique chemical structure.
How that structure leads to resistance to liver breakdown.
Its wide range of powerful clinical uses, from helping burn victims heal to fighting HIV wasting.
And importantly, its comparatively favorable safety profile, especially concerning the liver, when used appropriately in medicine.
I think the main takeaway for you listening is that oxandrolone really isn't just another steroid. It's proven itself as a medically valuable anabolic agent. It has a unique profile, and it's been providing real benefits in these tough wasting conditions for decades now.
Decades of clinical use supporting that.
So here's a final thought to leave you with. We've seen clear evidence for oxandrolone's effectiveness and its relatively good safety record, especially when you weigh it against the burden of conditions like severe wasting or potentially sarcopenia. It makes you wonder.
What else is out there?
Exactly. What other existing compounds might we be underappreciating or under-researching for new uses? Could a deeper dive into the nuanced pharmacology of known drugs, like we've done today with oxandrolone, help us reshape how we tackle some of these widespread health challenges in the future?
It's a compelling question about finding new potential in what we might already have. Food for thought.